So premature ovarian failure. It's another name for early menopause, basically. It's also called premature ovarian insufficiency. The average age of menopause is around 51, but menopause is not technically considered abnormal unless it occurs before the age of 40. As in menopause, the gonadotropins LH and FSH are elevated in premature ovarian failure, but the ovaries do not respond and therefore estrogen levels are low. Remember hypogonadotropic hypogonadism that we discussed previously? Well, in contrast, premature ovarian failure is called hypergonadotropic hypogonadism because you have the anterior pituitary signaling the ovaries with the increased FSH and increased LH, but no result, which is why you get the decreased estrogen. So how is premature ovarian failure a bad thing? Well, along with infertility, early menopause also puts women at increased risk for osteoporosis and heart disease, since, as you know, estrogen is normally protective against these diseases. The condition is most often idiopathic, but in some cases it can be caused by autoimmune disorders or pre-mutations of Fragile X syndrome. On the boards, anovulation may show up as part of an infertility case scenario, so you want to keep the possible causes of anovulation in mind. Of this list, polycystic ovarian syndrome, PCOS, is the most common, so with minimal information about the patient, you have the best odds that this is your diagnosis. We'll discuss this afterwards. Another common cause is eating disorders, particularly anorexia or bulimia, because extremely low BMI leads to loss of pulsatile GnRH release from the hypothalamus. Watch out for hints about abnormal weight loss, dieting efforts, or secretive eating patterns. These patients' amenorrhea is reversible with restoration to a healthy weight. Can you name a very common metabolic disorder that often presents with anovulation and amenorrhea? That's right, hypothyroidism. Please refer back to the endo chapter for the pathophysiology behind that. So as we said earlier, this next topic is very high yield for the boards because it's the most common cause of amenorrhea. It has lots of other symptoms as well and a quite complicated pathophysiology, so bear with me. So PCOS is an endocrine disorder in which LH levels are much greater than FSH levels. Do you know what the ratio of LH to FSH is considered diagnostic? 3-to-1 ratio. So it is associated with insulin resistance, and is thought to be due to high insulin levels causing an increase in GnRH pulse frequency, which in turn causes more LH than FSH to be produced. LH is released with greater pulse amplitude and frequency than normal, and it induces the theca cells in the ovary to make androgens. Therefore, you get symptoms of hyperandrogenism like hirsutism. This means you get hair in masculine patterns such as on the chest, face, and trunk. The continuously high LH also suppresses ovulation, so you will get amenorrhea and infertility. In terms of phenotype, PCOS is also associated with obesity. What's more, when you have increased androgens from PCOS and increased adipose tissue that is converting those androgens to estrogen, you can see an increased risk of endometrial cancer from those high estrogens. As you can see from the image here, you get a thickened ovarian capsule and cyst, numeral cyst actually, which are subcortical cysts. You might want to try to commit this picture to memory, and it's a pretty classic finding in the setting of this disease. And obviously Step 1 loves classic findings. This next image shows the sonographic findings of PCOS. Here you can see the hypoechoic cystic spaces. So what causes the cyst in PCOS? The cysts occur because the hormone that maintains the follicles, FSH, is low. Therefore, the follicles degenerate, leaving you with just cystic spaces. You'll see a string of pearls type pattern instead of one dominant follicle because you're not getting the normal process of one follicle becoming dominant and then rupturing during ovulation. The treatment of PCOS includes weight loss, oral contraceptives, gonadotropin analogs, clomiphene, spironolactone, or surgery. This will be covered again in the pharmacology section. The weight loss will help with the insulin resistance. The OCPs and gonadotropin analogs and clomiphene will help with the hormone imbalance. Spironolactone will help block the hyperandrogenic symptoms. One more drug that is commonly used in this disorder is a drug that you learned in endo as the most common treatment for type 2 diabetes. Remember what it is? That's right, metformin. It'll also help with the insulin resistance and add on to the weight loss. Staying on the subject of ovaries, this fact summarizes the different types of ovarian cysts. Most of these cysts are harmless, but they can cause problems when they rupture or bleed. So occasionally these cysts do have to be surgically removed. As you can see from this ultrasound, cysts are usually circular hypoechoic lesions. So follicular cysts are swollen, unruptured Graafian follicles. They're associated with high estrogen states like endometrial hyperplasia. If they rupture during the middle of the menstrual cycle, they can cause pain. What is that called? Mittelschmerz, that's right. The corpus luteum cysts occur when there is hemorrhage into a persistent corpus luteum, which is formed after an egg has been released from a follicle. Remember that this is the part of the ovary that secretes progesterone. Atheca lutein cysts are also called functional cysts, and they occur in the setting of high gonadotropins with ovulation. They're often bilateral and can be associated with choriocarcinomas and moles. Very important. Hemorrhagic cysts occur when a blood vessel ruptures, leading to retention of blood. These usually self-resolve and are of little concern. So here's a flash quiz. What is the most common cause of anovulation? Polycystic ovarian syndrome, and don't you forget it. Nascent adnexal mass in postmenopausal women equals ovarian cancer until proven otherwise. Risk of malignancy increases with advanced age, infertility, endometriosis, PCOS, and genetic predispositions, such as BRCA1, BRCA2, and hereditary non-polyposis colorectal cancer, HNPCC, gene mutations. What marker can be used to monitor the progress of disease? You have CA125. Of note, we do not use it to screen for ovarian cancer. That's because both its sensitivity and specificity are low. So there's a long list of ovarian neoplasms coming up, so bear with me. I'll cover the benign ones in this video. So let's start off with ovarian non-germ cell tumors. The serous adenoma make up 45% of ovarian tumors. They are often bilateral, and they tend to be lined with fallopian tube-like epithelium. You can see here a picture of a pretty big serous adenoma. The mucus adenoma is typically a multilocular cyst lined by mucus-secreting epithelium. You can see the mucus-secreting cells up here. Chocolate cysts, also known as endometrioid cysts or endometriomas, are the blood-filled cysts in ovarian endometriosis. They get larger during menses due to cyclic bleeding. They're called chocolate because the cyst is filled with dark reddish-brown blood. But we'll delve more into this endometriosis later on. Teratomas make up 90% of ovarian germ cell tumors and characteristically have cells from 2 or 3 different germ layers. Mature teratomas are also called dermoid cysts, and here we have an example of a mature dermoid cyst with cutaneous structures from the ectoderm, including hair, which you can see here. This one was found to have a neuroglia. There's another teratoma that you see in the book that has teeth and hair structures. Any picture with mixed histology is the hallmark of this disease, with simultaneous appearance of 3 germ layers of tissue. One notable type of mature teratoma is sometimes separately tested as struma ovarii, which means goiter of the ovary. It is usually benign but can occasionally be malignant. What sets them apart is that they contain functional thyroid tissue and can secrete thyroid hormone. So how do you think these patients would present? With hyperthyroidism. All right. So Brenner tumors. These are rare ovarian tumors that can mimic transitional epithelium. Do you remember where else in the body is this epithelium found normally? That's right, in the bladder. They're usually benign and unilateral. On gross pathology, you'll see a solid, sharply circumscribed yellow-tan mass. On histology, you'll see a bunch of coffee bean nuclei, and they're embedded in a fibrous stroma. So here are the beans, like I was circling earlier, and here's the stroma, all this lightish violet stuff. Fibromas are benign tumors characterized by bundles of spindle-shaped fibroblasts. One presentation of an ovarian fibroma is Meigs syndrome. Meigs syndrome has the triad of ovarian fibroma, ascites, and hydrothorax. You can see this huge fibroma over here. Typically, the hydrothorax or pleural effusion is on the right side, but nobody's sure why that is. Thecomas are similar to granulosa cell tumors, which we will discuss later. Thecomas produce estrogen and can present as abnormal uterine bleed. You can see here on the image that the nuclei with oval to spindle morphology, abundant cytoplasm, and they're pale and vacuolated. Just like what? Granulosa cells. So here's a flash quiz. Histologically, which ovarian neoplasm has fallopian tube-like epithelium? The answer is serous cystadenoma. So moving on to the malignant neoplasms. It's a pretty meaty topic, so hang in there with me. To give you a little bit of context, ovarian cancers can be divided into three main classes based on the type of tissue that they arise from: epithelial, stromal, and germ cell. Many of them have characteristic changes in circulating hormone levels, which is usually the fastest and easiest way to ID the tumor you're given in the question stem. While the most common type, epithelial, occurs mostly in postmenopausal women, the germ cell tumors occur mostly in younger women and adolescents. Now, so while mature teratomas, aka dermoid cysts, are benign, immature teratomas tend to be much more aggressive and malignant. Like most tumors, the less differentiated the cells, the more aggressive. You can see here, this looks like an aggressive tumor. Do know that these are less likely to have struma ovarii compared to mature teratomas. So granulosa cell tumors, they're found in the stroma of the ovary. The peak incidence is in patients in their 50s. Thinking about what granulosa cells do, can you predict how these would present? That's right, they secrete estrogen. So they build up the endometrial lining and can present with abnormal uterine bleeding. They can also be associated with early puberty, in addition to endometrial hyperplasia and carcinoma. On histology, you'll see that granulosa cells have Cal-Exner bodies. You can see they're here in the circles, which are small follicles filled with eosinophilic secretions. These are pathognomonic for granulosa cell tumors, so make sure you commit them to memory. I like to remember it by recalling that I need to call my granny, so I know that Cal-Exner bodies are associated with granulosa cell tumors. The malignant form of the generally benign serous cystadenoma is the serous cystadenocarcinoma. They make up about half of all ovarian tumors, and they are distinctive in that they are frequently bilateral. This is one of the cancers that presents with psammoma bodies. And what are psammoma bodies again? They're essentially these microscopic round collections of calcium. You can see them here and here and here. As a quick review, can you remember all the tumors that may present with psammoma bodies? The answer is in the name. So if you think psammoma, so the letters that I capitalize will help you remember them. P for papillary carcinoma of the thyroid, S for serous cystadenocarcinoma of the ovary, M for mesothelioma, and M for meningioma. This image happens to be that of a meningioma, by the way. So, the malignant form of mucinous cystadenoma is a mucinous cystadenocarcinoma, characterized by intraperitoneal accumulation of mucinous material called pseudomyxoma peritonei. You can see it in the picture here. A tumor from what other structure could also present with pseudomyxoma peritonei? That's right, the appendix. Good. Dysgerminomas are equivalent to male seminomas, which we'll talk about later on. These are characterized by elevated ACG and LDH. LDH stands for lactate dehydrogenase. So what benign tumors are choriocarcinomas associated with again? We talked about them earlier. That's right, molar pregnancies. You can also see it with ectopics and miscarriages. You also see them with thecalutean cysts. So, these cells are large hyperchromatic syncytial trophoblasts, which, if you'll remember from the embryology section, are the large multinucleated cells found in the embryo's placenta that make up the outer layer of the chorionic villi. These will secrete ACG, which helps make the diagnosis. These spread hematogenously, and the mets can be fatal, most often in the lungs. An important point for this tumor that may appear on your board is that there are no chorionic villi. This is a marked difference from molar pregnancies, for example. Yolk sac, or endodermal sinus tumors, are aggressive tumors typically found in children under 3. As scary as this is, they respond very well to chemo. So these days, kids don't die from this condition if it's treated in time. Yolk sac tumors are characterized as yellow, friable solid masses with Schiller-Duval bodies. These look like mini glomeruli and are basically pathognomonic for this condition, so keep that in mind. You can see them right here. In terms of making the diagnosis, can you remember what is the tumor marker for this cancer? It's an elevated alpha-fetoprotein, AFP. So, USMLE is obsessed with this one. Krukenberg tumors. These are GI tumors, usually adenocarcinoma of the stomach, that metastasize to the ovaries bilaterally. They are characterized by mucin-secreting signet cells. As you can see in the image, the cell has a nucleus pushed to the edge. So for example, here's the cell. You can see how the nucleus is pushed to the edge over here, making the cell look like a signet ring. What other cancer do you see these cells in? You may remember from GI that they're seen in gastric cancers. Helpful correlation, no? So here's a flash quiz for you. What are the tumor markers for this germinoma? The answer is lactate dehydrogenase and beta-HCG.